हाय एवरीवन, वेलकम बैक टू GM4T एकेडमी। मैं हूं डॉक्टर राहुल गुप्ता और आज हम शुरू करने वाले हैं एक ऐसा टॉपिक जो आपके लिए सिर्फ एग्जाम्स के लिए नहीं बल्कि रियल लाइफ प्रैक्टिस के लिए भी गेम चेंजर बन सकता है। एपिडेमियोलॉजी ऑफ क्रोनिक एंड नॉन कम्युनिकेबल डिजीजेस। बट लेट मी स्टार्ट विद अ क्विक रियलिटी चेक। क्या आप जानते हैं कि दुनिया भर में 4 में से 3 मौत किस वजह से होती है? इट्स नॉट ड्यू टू इन्फेक्शंस लाइक मलेरिया, ट्यूबरकुलोसिस और कोविड। इट्स NCDs, नॉन कम्युनिकेबल डिजीजेस। साइलेंट किलर्स जो धीरे धीरे हेल्थ को कंज्यूम करते हैं और सबसे ज़्यादा बर्डन बन गए हैं ग्लोबली। और ये सिर्फ एक मेडिकल टर्म नहीं है, ये हार्ट अटैक है जो किसी 40 ईयर ओल्ड को जिम से वापस आते वक्त होता है। ये डायबिटीज़ है जो आपके पेशेंट की आंखों और किडनी को छुप छुप के डैमेज कर रही है। बाय द एंड ऑफ दिस वीडियो आप क्रोनिक डिजीजेस को क्लियरली डिफाइन कर पाएंगे, इनका एपिडेमियोलॉजिकल इंपॉर्टेंस समझ पाएंगे, प्रिवेंशन के स्मार्ट टूल्स के बारे में कॉन्फिडेंटली डिस्कस कर पाएंगे। सो हियर्स हाउ टुडेज वीडियो इज गोइंग टू फ्लो। पहले एक क्विक ओवरव्यू करेंगे क्रोनिक डिजीजेस का कि वो क्या होती हैं, कैसे होती हैं। देन वी विल ब्रेक दिस डाउन इनटू 4 मेजर सेक्शंस: definition and characteristics, burden and risk factors, natural history and gaps, and prevention and WHO strategies. और एंड में आएगा एक छोटा सा रैपिड फायर रिवीजन राउंड जिसमें पूरा लेक्चर सिर्फ 2 मिनट में रिवाइज करेंगे। तो रेडी हो? चलिए शुरू करते हैं GM4T एकेडमी के साथ इस नए लेक्चर की। So in this section, we are going to talk about the definition and key features of chronic diseases. But before we dive in, just pause and think. क्या हर बीमारी का इलाज होता है? What if there are diseases that don't go away in days or weeks but stay for months, years या कभी पूरी जिंदगी? Let's break down what exactly qualifies disease as chronic and how these are different from acute illness.
Chronic diseases are impairments or deviations from normal structure or function that persist over a long period and lead to lifestyle modifications. So they are typically progressive, non-reversible, and require long-term care or rehabilitation. I want you to pause right here and write this in your own words in just one line. Ready? Go. Okay, so let us now proceed to the characteristics of chronic diseases. Chronic diseases have long duration. The long duration is considered more than 3 months. They are often permanent or progressive. They may cause residual disability. They require ongoing medical supervision. And they often need lifestyle modification or rehabilitation. Okay, Let's now test your understanding. Let's say if a patient has asthma for 6 months, requires inhalers daily, and can't perform physical activity normally, is it chronic? Just think about it. Well, yes, it is chronic because it fulfills the key features such as long duration, right? Long duration is more, that is, here it is 6 months, requiring daily care, requires inhalers daily, and can't perform physical activity normally, which is functional limitation. So these are the characteristics that can help us to understand whether a disease is acute or chronic. So here we will draw a simple table of differentiation between acute illness and chronic illness. Acute illness is sudden in onset, whereas chronic illness is gradual or persistent, right? Acute illness is short term, while chronic illness is long term, where it may last from months to years. Acute illness is usually curable, while chronic illness is rarely curable. Acute illness can give disability, but it is very minimal disability, while chronic illness can cause a lot of disability. So yeah, disability plus plus. Most students actually confuse the term chronic with serious. Chronic illness does not have to be severe or serious. It just has to last long and need ongoing care. So do not make that mistake again. Okay, let's give some examples over here. Flu is not chronic. Okay. Dengue, not chronic. While on the other hand, we have arthritis, diabetes, COPD, hypertension. These are all textbook examples of chronic illness. So some examples of common chronic diseases include cardiovascular diseases like heart attack, stroke, and stroke can be considered as a cerebrovascular disease. Diabetes mellitus, hypertension, cancer, respiratory illness. We have asthma, COPD, chronic kidney disease, mental illness like depression, musculoskeletal disorders like arthritis. Okay, if I ask you, how about road traffic accidents? Are they common chronic diseases? Well, the answer is no, but the disability due to these road traffic accidents can become chronic in nature. All right. All right, a quick quiz for you. Come on, tell me tuberculosis is a chronic disease. True or false? Yeah, think about it. Well, TB is a communicable disease. It is an acute illness, though it can be long lasting, but it is not a chronic disease.
All right, before we move to the next section, here's your mini task. Comment down below one thing that now feels clearer about chronic diseases. One thing that still confuses you. Pause the video now and do it. या फिर एंड तक देख के वापस आके लिख लो, बट मेक श्योर टू डू इट. दैट्स हाउ यू रिवाइज. सो इन दिस सेक्शन हम बात करेंगे अबाउट समथिंग दैट ऑफ्टन शॉक्स स्टूडेंट्स एंड इवन डॉक्टर्स, the actual burden of NCDs. Here's something to think about. Why is it that in many hospitals, ICU beds are filled not with malaria or dengue patients, but with stroke, MI, COPD, or cancer patients? It's because chronic diseases जो दिखते नहीं लेकिन silently grow करते हैं are now the leading cause of death worldwide. Let's now dive into the numbers and realities.
According to WHO estimates of 2021, approximately 43 million people died from NCDs due to NCDs. This is basically 75% of all the global deaths. Which exclude pandemic-related deaths. Out of these 43 million, 18 million were premature deaths, that is, under the age of 70 years. Of these 18 million deaths, 82% of premature non-communicable disease-related deaths occurred in low and middle income countries like India. So overall, 73% of all NCD-related deaths are from LMIC. So this 43 million people, and out of all these 43 million people who died due to NCDs, that is globally, 73% of these deaths are from LMIC. Hence, NCDs are now the #1 killer, especially in developing countries like India. So let's see again that according to WHO estimates, these NCD related deaths that occurred in 2021 is 43 million people who died. Of these, let's say 75, which actually accounted for 75% of global deaths, which was NCD related as well as non-NCD related. So if 75% of global deaths were NCD related, then how many were non-NCD related? 25% deaths were non-NCD related. 25% deaths non-NCD related. Could be infectious disease, and one of the biggest causes at that time in 2021 was the COVID-19 pandemic. Okay, and then wait on. Yeah. So yeah, 25% non-NCD related deaths, 75% all global deaths were NCD related. That is 43 million people who died due to NCD. Out of these 43 million people, 18 million people died prematurely, that is before the age of 70 years. And of all the premature deaths, 82% were from LMIC. Of course, premature deaths, talking about NCDs. So those out of those 18 million deaths that were premature due to NCDs, 82% of premature NCD deaths were from LMIC. And even if we don't talk about the premature death, so deaths due to NCDs occurring either before 70 years or after 70 years of age, that is whether premature or not premature, 73% of all the NCD related deaths were from lower middle income countries, including India. Let's pause here and think for a while. Why do you think non-communicable diseases are more common in developing countries? I mean, look at here and look at the data over here. 73% of NCD deaths are from lower middle income countries. So please comment your reason. I'll explain one possible reason now. In LMICs, exposure to risk factors is rising. And those risk factors are tobacco, pollution, junk food, but the healthcare systems are not equipped for early diagnosis and management. So this could be one possible reason. I want you to think about it and comment your reason. Okay, so top 4 major NCD deaths are due to cardiovascular diseases. This is the leading cause, caused 19 million deaths, followed by cancer, responsible for almost 10 million deaths. Then the third leading cause is chronic respiratory illness. Responsible for 4 million deaths. And guess what is the next most common cause of death? Due to NCDs, diabetes mellitus, accounting for 2 million deaths worldwide. So these 4 account for 80% of premature deaths worldwide. 80%. That's quite a lot. Okay, 4 major causes: cardiovascular disease, followed by cancer, followed by chronic respiratory illness, and then diabetes mellitus. The 4 of them contribute to 80% of all the premature NCD related deaths globally. Okay, so mini quiz for you. Which NCD causes the most deaths globally? Come on, tell me yes. If you're saying cardiovascular diseases, then you are correct. While talking about the risk factors for NCDs, it would be convenient to divide those risk factors into 3 different categories. One is behavioral, second is metabolic, and third is environmental. So when we talk about behavioral, we are actually talking about tobacco use, both smoking and smokeless, both forms. So smoking would include cigarette and BDs, whereas smokeless would include khani, jarda, gutka, pan masala. Another behavioral key risk factor is harmful use of alcohol. It's harmful use, whether it is a country liquor or proof liquor, anything, but harmful use of alcohol is a behavioral risk factor. Third is unhealthy diet, that is high in salt, sugar, and trans fatty acids. With respect to the trans fatty acids, we will be covering it in details when we cover the topic of nutrition. Okay. The fourth behavioral activity key risk factor is physical inactivity. So these are 4 behavioral risk factors. Okay, next is the metabolic risk factors. So in metabolic risk factors, increased blood pressure, increased blood sugar, deranged lipid profile, that is dyslipidemia, and overweight or obesity. These are the metabolic risk factors. Next is the environmental risk factors, that is air pollution. So if someone asks you that what are the risk factors for NCDs, how we can proceed for that is the risk factors are basically divided into 2 parts. One is modifiable risk factor and another is non-modifiable risk factor. Okay, so what we talked over here are the modifiable risk factors. What we have not covered over here is the non-modifiable risk factors, which would include, come on, guess, age. As the age increases, the risk factor increases. Our age can never reduce, so it is a non-modifiable risk factor. Another is gender, family history or genetics, and fourth is ethnicity. Please write in the comments section if we have missed any other non-modifiable risk factor. So to summarize, there are two types of risk factors for NCDs. One is modifiable risk factor and another is non-modifiable risk factor. Under modifiable risk factor, we have behavioral risk factor, metabolic risk factors, and environmental risk factor. Whereas under non-modifiable risk factors, we have age, gender, genetics, ethnicity. There's a common mistake that people think genetics is the main reason for non-communicable diseases. But no, most cases are due to behavioral and environmental risk factors. So behavioral and environmental are more common. Behavioral and environmental are more common, and genetics is less common cause. Whereas behavioral, rather I would say, the modifiable risk factors are more common cause. And that completes the topic of epidemiological burden of non-communicable diseases. See you in the next section.
Hey, just pause for a moment and think. Why do you think NCDs are common in developing countries? Comment your reason. I'll explain one possible reason now. In low and middle income countries such as India, exposure to risk factors to tobacco, pollution, and junk food is rising, but healthcare systems aren't equipped for early diagnosis and management. Alright, before we move on, here's your quick challenge. Comment below which NCD shocked you the most in terms of global deaths. One risk factor that you think India urgently needs to tackle. Let's reflect, क्योंकि सिर्फ पढ़ना काफ़ी नहीं होता, समझना ज़रूरी है. So in this section, we are going to explore a fascinating question. Why is it so difficult to pinpoint the exact cause and onset of most chronic diseases? Think about this. आपके पेशेंट को डायबिटीज़ है, बट कब से? किस वजह से exactly? No one can tell for sure. That's because the natural history of non-communicable diseases is full of gray zones. Let's explore where these gaps lie and why they make prevention so tricky.
Let us understand what is the natural history of disease. It means the course of a disease from its beginning to resolution without any medical intervention. So here's the disease, which is beginning till its resolution, and that too without any medical intervention. So that is basically the natural history of disease. But in non-communicable disease, this timeline is unclear, unpredictable, and is full of gaps. So if we talk about NCDs, natural history is basically very sluggish, very much unknown, unclear basically. So let's find out the gaps in the natural history of a non-communicable disease. So gap 1 is absence of a known agent. Many non-communicable diseases don't have a clearly defined causative agent. However, in some cases, such as silicosis, we have a known agent. In case of mesothelioma, again we have a known agent, that is asbestos. But how about we call hypertension, diabetes mellitus, or cancers? There's no single identifiable cause. No single identifiable cause. Second gap is multifactorial causation. Pulmonary tuberculosis, we know it is caused by Mycobacterium tuberculosis. right? But here it is a cocktail of risk factors. As we discussed in the previous section, there are multiple risk factors: environmental risk factor, behavioral risk factors, and genetic or constitutional risk factors. So that is why it is difficult to identify the single factor that is responsible for causing this non-communicable disease. So that is why we do not use the term cause. We don't use the term cause, okay? Instead, we use the term risk factors. We use this term. Why do we use this term? Because risk factor means that something that increases the probability, but not a guaranteed cause. For example, in obesity, as you mentioned, there's a if we talk about the multifactorial causation, then obesity can be because of physical inactivity. It can be because of unhealthy diet, but it does not mean that both of them are the causes. They are just risk factor. That if dyslipidemia is there, the risk of obesity will increase, but it will not definitely cause that. So another gap in the natural history of a non-communicable disease is multifactorial causation. Third gap is the long latent period, very long latency. Except HIV, usually in viral infections which are of a respiratory nature, they usually have an incubation period of maximum, let's say, on an average 7 days. But here, it can often be for years. So, for example, smoking that may cause lung cancer. It may take 15 to 20 years to develop the disease. So, gap 3 is long latent period. Let me write an example for you. Smoking leading to lung cancer. It might take 15 to 20 years. But sometimes we find precursor lesions like oral leukoplakia or cervical dysplasia, but not always. So by the time the disease appears, it's often too late for primary prevention. So here I need to ask you, what is primary prevention and what is the level of intervention that is given at primary prevention? Please write down in the comments below. And the gap 4, fourth gap, is indefinite onset. NCDs start very quietly, no fever, no red flag. So, for example, diabetes and hypertension, they may exist for years before diagnosis. Organ damage begins before the symptoms. So, many cases are diagnosed accidentally during unrelated checkups. So, there is a delayed detection. That leads to complications. That is the organ damage, and which causes higher cost of care, increases the cost of healthcare. So in summary, there are 4 gaps that are responsible for the understanding the natural history of disease, of non-communicable disease, that is absence of the agent, multifactorial causation, long latent period, and indefinite onset of the disease. So because of these 4 gaps that we have discussed, because of the gaps, prevention becomes harder. So as a result, we focus on risk factor surveillance, mass screening, behavioral change campaigns, and early life interventions. Focus on risk factor surveillance, mass screening, like in camps, we screen for high blood pressure or high blood glucose, that is diabetes mellitus, or pap smears for cervical cancer. Third is behavioral change campaigns. And fourth is early life interventions. For example, healthy schools. There's a common misconception. People think that diseases just happen suddenly, but NCDs are years in the making. And now I think you probably know the reason why. If not, then think about the gaps in the natural history of non-communicable disease. You will get your answer. Okay, so this wraps up gaps in the natural history of NCDs.
Okay, before we go to the final part, let me ask you this. Comment below. Which gap do you think is the biggest challenge in managing NCDs? And what's one way public health can overcome it? क्योंकि समझना प्रिवेंशन की शुरुआत है. सो फार हमने जाना कि क्रोनिक डिजीजेस का लोड कितना ज़्यादा है और उनका नेचुरल हिस्ट्री कितना अनप्रिडिक्टेबल है. अब सवाल ये उठता है, क्या हम इन डिजीज को रोक सकते हैं, और अगर हाँ तो कैसे? द गुड न्यूज़ इज वी कैन प्रिवेंट देम, बट वी नीड मल्टी लेवल एक्शन फ्रॉम इंडिविजुअल्स टू गवर्नमेंट्स. Let's now dive into the actual strategies for prevention and control of NCDs.
NCD prevention is complex because they are not caused by germs, they are caused by lifestyle, environmental behavior, and sometimes policy failures as well. That's why we need individual behavior change, community level awareness, and policy level interventions. So, if we are asked that at what level or how can we prevent NCDs, so the answer would be divided into three parts. Individual behavior change, community level awareness, and policy level interventions. In the immediate priority interventions, these interventions are cost effective and they have a high impact. They are at individual level. Okay, so first priority intervention would be tobacco control, meaning thereby ban on smoking in public places, graphic warnings on packs, ban on tobacco ads, and high taxes on tobacco. That is making the tobacco and its products expensive. Second immediate priority intervention at individual level is alcohol control, where limit access to alcohol, banning its advertisement, and again increasing taxes. In the dietary improvements, reduce salt intake in food, remove trans fats from diet, and mass media promotion of healthy eating. There are some additional facts that I would like to share with you. For example, WHO has an empower strategy for tobacco control, whereby M means monitor tobacco use, P means protect people from tobacco use. Protect people from tobacco use. O meaning offer help. W, warn about dangers of tobacco. E, enforce bans on ads related to tobacco. And R, raise taxes. So more or less what I have told you in tobacco control, that is ban on smoking in public, graphic warnings on packs, ban on tobacco ads, and increasing taxes on tobacco. So that is basically a part of WHO Empower strategy. So if a question is asked, then I would suggest that you better write Empower strategy rather than just vaguely writing about tobacco control. That would help you add more points to your assessment. Here's another fact about salt intake. So currently we are eating sodium. Basically, sodium is the important component of the salt from which we need to refrain. Currently we are having sodium 4.3 grams per day, and salt consumption is 10 gram per day per person. That's what I'm talking about. But what is recommended by WHO is almost half of what we are consuming right now. That is sodium less than 2 grams per day per person, and salt less than 5 grams per day. So that is again additional value when we are talking about dietary improvements and talking about reduced salt intake in food. So how much and what is the current scenario? You can always mention that, and what is recommended by World Health Organization. So this brings us to a question whether raising taxes is a healthy strategy. What do you think? Comment in the section below. Okay, so we have covered under prevention of NCDs, individual behavior change, where we have talked about tobacco control, alcohol control, dietary improvements. Now we are going to talk about community level awareness. So community level awareness is a low cost population level intervention, which includes the following: nicotine de-addiction programs, ban on alcohol while driving, restrict marketing of junk food, making healthy food affordable, nutrition counseling in clinics, and physical activity promotion in schools or workplaces. So these are the community-wide preventive measures that benefit even those not seeking healthcare. Is there any other low-cost population-level intervention that is coming to your mind right now while we are talking about this? Please mention in the comments. So under low-cost population-level interventions, we also have cancer-specific intervention. For example, hepatitis B vaccine. It prevents liver cancer. Human papilloma virus vaccine for cervical cancer. Control of carcinogen exposure. For example, asbestos or polluted water. So, if a girl child gets human papilloma virus vaccine at the age of 11, how does it help public health 10 years later? Can you think of anything? Well, cervical cancer prevention has a long-term impact. So that is how, if the child gets vaccinated at an early age, this might help her stay away from cervical cancer. And if she does not have cancer, a lot of public health implications like out-of-pocket expenditure that I can think of right now would be avoided. All right, so we have discussed so far individual level behavior change, community level awareness. Now we are going to talk about policy level interventions. Policy level interventions are service based and systemic measures, which include mass screening for blood pressure, now I would say for hypertension, diabetes mellitus, and cervical cancer. Second is health education. Third is pollution control. Fourth is strengthening primary health care. And last is political will for anti-smoking, anti-alcohol laws. These measures reduce the complications and mortality in already diagnosed patients. Hence, it's a level of what kind of intervention? It's tertiary prevention. Why do we need to talk about integrated approach to NCD control? Because prevention strategies for heart diseases are also useful for diabetes, cancer, and COPD. Why? Because the risk factors are common. So whether it is diabetes mellitus or hypertension or cancer, some cancer and respiratory illness like COPD, we need to focus on the following. A, health promotion. Come on, tell me, what level of intervention is this? Level of intervention, of prevention. Is it primordial, primary, secondary, tertiary? Tell me. Second is risk factor management. Third is early detection. And fourth is multi-sectoral collaboration. World Health Organization recommends 3 steps to collect data for surveillance of non-communicable disease. It is also called as, in short, WHO STEP survey. The first step is the questionnaire that would collect the data on demography, dietary history, tobacco use. Physical measurements would include anthropometric measurements, blood pressure also, and height, weight. And biochemical would include blood sugar and cholesterol levels. This survey helps us in monitoring trends, plan intervention, and assess the impact. So we get to know using this survey and this approach, steps approach, that what is the prevalence of hypertension, or what is the prevalence of other risk factors that are prevailing in the community. And we can say, let's say, for example, the trend is that the obesity is on the rise. So obesity is a metabolic risk factor for the non-communicable disease, and then we need to plan intervention. So maybe at the policy level, we might say that okay, in the parks we should plant those kind of instruments which are self-helping in nature. Those that help us in the parks. There are different playwares that can be used for exercise. Overall, just in order to reduce the obesity, maybe playgrounds are planned. So as a result of that, the assess and the impact will be assessed. So impact is not short term; it is a long term impact. So what we are not by impact, we mean that we're not actually looking at okay, after 1 year how many people are not obese now. What we are planning to see is that as a result of obesity, had obesity been there and no interventions been there, then obesity would have led to maybe diabetes, hypertension, some form of cancers. So in long term, we are trying to see, okay, then that if that intervention is given, then in long term, what percentage of those diseases occurring due to obesity can be reduced. So these are basically, that is the importance of surveillance. So these are the uses of WHO STEPS approach to non-communicable disease surveillance. Next is the global plans and goals that have been set to tackle non-communicable disease. One was WHO Global Action Plan 2013 to 2020. Its goal was to reduce premature NCD deaths by 25% by year 2025. This deadline has reached. Now we are looking forward to the targets of the Sustainable Development Goals. So Sustainable Development Goal 3.4 says reduce premature deaths by one third. One third meaning by 33% by the year 2030. So by 2025, the target was to reduce premature deaths by 25%, and by 2030, Sustainable Development Goal 3.4 says to reduce the premature deaths by 33% by 2030. So target has been reduced from 25% to 33%.
Before we end this section, let's reflect. Comment down below. Which prevention strategy do you think is the most powerful in India today? And one policy you would love to see our government implement soon. This is where public health meets real life. Alright, you have made it to the end of the lecture, and now it's time for rapid fire revision. Let's revise the entire topic in just under 2 minutes, so tighten your seatbelts.
Alright, so let's fire up. Here's a rapid recap. Chronic diseases are defined as impairment or abnormal function that is long-lasting, non-reversible, and often progressive and require long-term care. Its key characteristics are duration is more than 3 months, it is often progressive, requires lifelong care, and it may cause disability. Acute illness is sudden and short-term, whereas chronic illness is gradual and long-term. Common chronic diseases include cardiovascular diseases, diabetes, cancer, COPD, mental illness. In 2021, according to WHO data, deaths due to non-communicable diseases comprised of 75% of all the deaths, that is 43 million deaths. Out of those 43 million deaths, there were 18 million premature deaths, and 82% of these deaths occurred in LMICs. So, the most common causes of mortality due to non-communicable diseases are cardiovascular disease, number 1, followed by cancer, followed by chronic respiratory diseases, and lastly, diabetes. The key risk factors include tobacco, physical inactivity, unhealthy diet, alcohol, and pollution. However, I would still suggest that we divide that into two parts, modifiable, non-modifiable, and in the modifiable, we go further for behavioral, environmental, and lifestyle, right? No, metabolic, I'm sorry. And gaps in natural history, there is no known agent, there is a multifactorial causation, the non-communicable diseases have long latent period, and fourthly, they have an indefinite onset. Prevention strategies, we talked about the prevention strategies at 3 levels: one at individual level, second at population or community level, third is at policy level. So overall, banning tobacco ads, raising taxes, promoting healthy diet, alcohol restriction, health education, screening plus early detection are the preventive strategies. Global plans include to reduce 25% non-communicable disease related deaths by 2025, and by 2030, according to Sustainable Development Goal 3.4, reduce the premature non-communicable disease related mortality by 1/3.
Phew, that was a lot. But now you have the entire topic at your fingertips. Comment and tell me what point made you go, oh wow, I didn't know this. And if you want the PDF notes for this lecture, check the description or pinned comment. Don't forget to like the video, सब्सक्राइब टू GM4T Academy. मैं हूं डॉक्टर राहुल गुप्ता. मिलते हैं नेक्स्ट टॉपिक में विद मोर इंसाइट्स एंड स्मार्टर लर्निंग. टिल देन, स्टे क्यूरियस, stay committed, and never stop learning. Thank you.